think of the jawline. I think of the gonial angle. For the lower part of the face, there are 4 components that I think of. I think of the chin zone. I think of the jawline. I think of the gonial angle. And I think of the facial width. Okay? Those are the 4 main components aesthetically that we have to be concerned with. For the chin zone, if we can turn it, if we want to do a chin enhancement or an augmentation, very simply, for females, I use a single injection point midline because a female face should have more of a heart shape, and the width of the chin down at the pagonian, which is the most projecting part over here, should be about the width between the eyes for a female. For a male, it's between the medial iris. They have a wider chin. So it's usually a single injection point. And then I take advantage of the uncontrolled flow of product to go ahead and determine which way I'm going to inject. If I want to project the chin forward, then I want my channel to be in that direction like that. And I go midline. Midline, it's rare that you're going to have any vessels. You have vessels on either side, the ascending mental vessels that are on either side. And you go down and there is that fat pad that is under the mentalis that you're kind of targeting. And a typical injection will be somewhere around 0.3 to 0.5 cc's of a pure high G prime product. If I decide that not only do I want to advance the chin, because the chin is the 3-dimensional structure, it has projection, it has width, and it has height. If I want to advance the chin but also have the chin be a slightly longer, then besides going ahead and treating the trunk of mentalis, which will lengthen the chin, my injection is in the drop technique where I go ahead and I inject this way. And so the product will flow backwards along my needle or cannula tract and will cause a vertical lengthening of the chin. And the drop technique is using a needle, lifting the chin up on the patient, putting your needle just under the chin and letting the chin fall back down. And you're resting on the periosteum because you want it to be a deep injection. That's a midline injection too, because you do have the paracentral ascending mental arteries, one of which is usually dominant and you don't know which one it is, and you don't want to cannulate those. And you inject very slowly using your free hand to form a little house for the product so that it stays where you want it to stay. That's for chin enhancement or augmentation. In a male, I'll use 2 injection points, and I have to make sure that I'm down on bone and I aspirate beforehand. You can, interestingly enough, when you're injecting for males, I don't like to change the way they look, but sometimes I want to give them just a little bit of something different. So I'll have a nurse or somebody hold the cap of the needle right here, and then you inject on either side. You can try that on your donor, and you'll create a little George Clooney cleft, if you want to create a little cleft on the chin. When it comes to the marionette zone, you can treat that with cannula coming across, or you can treat it with a needle injection, whichever you're more comfortable with. My needle injections for the marionette zone, when I'm down by the mandible over here on the mandibular border, my injection is the double scoop down and deep on bone, a safer zone. But once I start to move up the marionette zone towards the corner of the mouth, the mandible, the curve of the mandible means that if I go down over here and I put my product down on bone, right, I'm going to need a fair amount of product, what Sebastian calls surface volume coefficient. I'm going to need a fair amount of volume to project this area over here. And what muscle am I going to be in? I'll be in the DLI, and the lidocaine from the DLI is going to give the patient a funny smile for about a good half hour. And I don't like to do that, so my injection is more superficial when I start to climb up. And as I get to the corner of the mouth, it becomes even more superficial and immediately subdermal, because we understand that the inferior labial artery runs deeper, but it ain't that deep. maybe 4 millimeters or something like that, so we want to stay above it. So it's deep double scoop, and then as I slowly go up with a needle, I'm going more and more superficial, okay? If you take a look at the chin zone as a final note, you have this labiomental crease. And very often there's a vessel that runs right underneath it, the transverse labiomental artery.
Correct.
Okay?
Absolutely.
And if you go deep over there, you're going to go ahead and you're going to cannulate that. And as a result, there has been a case of blindness from the chin injection. That's probably the way that it went, I would imagine.
Mm-hmm.
So you want to stay intradermal with your injections here. If you're using a needle, if you want to treat a deep crease, I will never treat a deep crease without also toxinating it, because of the fact that the pull of the mentalis is going to deepen that crease. So you go ahead and you put a little bit of toxin at the base, deep. Okay? It could be small amount put on either side of the midline. You don't want to wander too far off the midline because you'll get into the DLI again, and you don't want to get involved with that. And I'll inject intradermal for the crease over here to soften it. Okay? If you want to use a cannula, you'll stay immediately subdermal. But that represents the termination of the buccal mucosa on the inside, the gingival mucosa.
Yeah, it's exactly, yeah.
Okay? So any injections above that and deep in that area are going to be inside the mouth. All right. Then we have the jawline. Mm-hmm. Jawline is a great thing to inject, and when it comes to the lower face, it's all about balance. It's about balance, be making a defined jaw and keeping things looking natural. It's a balance of light and shadow, because you want to create a shadow beneath the jawline over here. Okay? It's a balance between too much volume or volume and having the right amount of projection. In this area, below the maxillary border over here and above the mandible, in this entire area, to me, everything that is vital is deep. So I want to stay superficial with my injections. I commonly use cannula in this area. And what I will do is I will distract the skin like this, right? When I do my injections, because you can't do that now because of your gloves, but afterwards, if you pull your cheek out and keep your tongue resting against the mucosa on the inside, the buccinator stays in its place. The artery and vein are sitting on the buccinator, and so what you're doing is you're pulling and distending out the fat, the platysma, and the subcutaneous tissue of the cheek, and so you're creating a bigger space of a safety for yourself. So I'll always distract the cheek when I'm doing the lower face over here. And I'll put my cannula in, and you can run it either this way or you can run it this way, whichever you want. Most of my injections there are done subdermal in order to support the cheek. When it comes to the jawline, I have an unusual way of approaching the jawline. Again, it's my way. It doesn't mean it's the right way, but it's just the way that I do it. I ask the patient to clench their teeth. That tells you the anterior border of the masseter muscle. And then you got to think in terms of a vein, artery, nerve. Right?
Yeah.
So that's right. The vein could be sitting on top of the masseter, coming through the anterior portion of the masseter, or just anterior to the masseter, and then more medial to that, you have the artery. What I like to do is I like to make my entry point for the cannula right over the artery. Again, remember, we're talking 3D, so I'm not trying to bring the artery into play. I want it to stay deep. So I pinch the skin up. I go ahead and just make a little nick inside the dermis to be able to get the cannula in. Then as I approach again, as I go in, you flatten your cannula out and you stay in the subcutaneous plane. Do you see any major vessels here at all? Because there aren't any. So I'm staying in the subcutaneous plane, and my typical injections will be done a half a centimeter or so above the mandibular border because of Cotofana's glide plane here. I don't want to inject right on the border in a gliding plane and then have the product scoot underneath the border. So I'm usually sitting about a half a centimeter to a centimeter above, and my target in males is the gonial angle. So I'll go across like this towards the gonial angle, and then I can feather it up like this in a little bit of a triangle with the base over here to mimic a masseter muscle and to give them a little more volume. If you want to go ahead and do the vertical aspect, you can do the same thing from this approach. But if you go ahead and you approach from this point of view right here, okay, and you try to, which is much more comfortable in a lot of patients, I mean, as far as your hand position is, and what happens is as you start to push your cannula forward, if you go down a little bit too deep, look where I am. So you don't want to get involved with that. I'm not saying that you're necessarily going to go ahead and rupture it, even though you'll feel a pop because the vein is in a canal, but you'll cause one hell of a bruise if you don't go ahead and inject in, even if you're just pushing your cannula there. So I prefer to start over trouble and move away. If I want to flip my cannula around from the same hole, I'm moving away from danger again. That's just the way that I do it. And my injections are superficial here. There are a lot of excellent injectors who like to inject deep to the masseter. Okay, and they find that the longevity of the product is better. They find that the tug on the bone over there, because of the injection over there, will actually cause onlay of more bone, and that they actually can get an increase in the width of their bigonial width in their face. But I like to stay superficial, to stay away from problems, and the only time that I break away from my superficial injection pattern for the entire lower face over here is when I'm dealing with the gonial angle. There's only one muscle that goes behind the gonial angle over here. The only muscle fibers that you're finding over here are only one muscle. It's not going to be the masseter. It's going to be the platysma. Okay? And that's what he's holding in his hand over here. It's like a blanket that covers the whole area, right? Yeah. Very often it could be all the way back there. So you're going to have to pierce through most probably the platysma, and you want to find the gonial angle, which is more anterior than most times that you think. It's sitting right about over here, and the masseter ends over there. And if you put your product down over here, especially in a male, and you go ahead and you're putting this down on bone, and I'm not going to do that right over here, you will project the angle so that it makes them look more cut. Mm-hmm. We can wipe that off now. So that's the only time that I go down. I use a needle. I use a 27 gauge needle with a full G' product, high G'. And my trick for this, to let you know, is that if you put your fingers over the angle of the mandible like this on your free hand, and then guide your needle like this, you're going to hit bone. And if you feel bone, you press the plunger. I see a lot of people injecting it this way, but the problem is it's a very easy miss and an access into the major vessels that he calls small, that I think I'd have a heart attack about if you ever touched any with vessels behind there. So if you don't feel bone, you don't press on it. And my goal here also is to really give it the projection in the direction that I'm showing you the cannula is going. Do I do that in females? It's something for you to think about. What happens in the female as she matures is that the L shape of the mandible that we see so beautiful over here, which becomes even more L-shaped in men for some reason, with the loss of the hormonal effects, the L turns to an I. It goes like that, just like he's showing you. It goes from an L like that, and then it starts to become an I. And as it becomes an I, as you know, the shortest distance between 2 points is a straight line. And that's why you get an excess of tissue that can accumulate over here. You know, there's not a lot of tension to keep that tissue away from the jowl. So that contributes to the jowl, number one, and it also displaces this gonial angle forward and up. So in a female, it would be here in a mature female. That's a female that's over 45. If you go ahead and you inject the bone over here in a female, then what you're doing is you're drawing attention to the fact that the mandible is shorter and it's a more aged look. So in a female, when I go in and I'm having a mature female that I'm doing the angle of the jaw, don't aim for the gonial angle because it's over here. Recreate what looks like a gonial angle that's further down. Lengthen the vertical ramus of the mandible, and you'll give them a more youthful appearance. Therefore, you don't have to inject down on bone in the mature female. Okay? Look for where that gonial angle is. I think that just about covers it.